So our first speaker is Dr. Sing Long Yi from Taiwan, and he's going to speak about no reflow phenomena, tips and tricks, and it is virtual lecture. Is he with
My
us
name is
online?
Yeshen Long.
Yes.
I'm the interventionist from Taiwan, Taipei. It's my great honor to share my talk in the GIS. My topic is no referral phenomenon. I have nothing to disclosure. No referral phenomenon occur almost 0.6 to 2% cases in the PCI, and more than 20% patients have the no referral phenomenon during AMI, and less than 2% in the elective cases. The definition of the no referral phenomenon is TIMI flow less than 2, and the outcome will be worse than the TIMI 3. There is some cause of the no referral phenomenon. And maybe the lesion is the thrombus content is too much, like ACS PCI or the elective PCI, they have the thrombus rich lesions. Another one is the SVG PCI. Or we have some cases in the rotor arresterectomy. During that time, there is a no reflow phenomenon is occurred. There is some mechanism of the no reflow phenomenon. And for the graph A is during the AMI. AMI there is some tissue damaged. So the myocardial damage will be swelling after the injury. So the microvascular will be constrict, and maybe there is a microvascular spasm, or there is some debris of the thrombus is downstream to the more small vessels. For the elective PCI, they have no tissue injury, but there is still some micro debris obstruct the very small vessel. Maybe another mechanism is a microvascular spasm. This is a capillary phase. There is some maybe the myocyte is swelling to contract the vessel and have the red blood cell stagnation, maybe the microthrombi in the distal. So there is a no reflow phenomenon occurred. There is some risk factor for the patient and the angiography. And for the patient, the female gender and the age more than 65 years old, hypertension, diabetes, hyperlipidemia, childbirth score more than 3, or the delay presentation of the STEMI cases, or the poor renal function, or the increased inflammatory markers. For the angiographic risk factor, they have the high thrombus burden lesion, or the plaque composition is, for example, the lipid-rich plaque, or there is a reperfusion time more than 6 hours, or SVG PCI, or the lesion longer than 0.5 centimeter, or dissection, and thrombus migration, or sometimes it's vasospasm. I have some example for the no reflow phenomenon. For the first one is the STEMI cases. This is the 62 years old male patient. He is a smoker, have the diabetes, hypertension, and the hyperlipidemia. he have the STEMI for the LAD. This time is for the primary PCI. And there is some lesion in the circumflex, but the capillary lesion, I think, is the LAD. So for first one, and I carefully wiring, then and use the small balloon to dilatation. As you can see, there is a very big thrombus stuck in the proximal of LAD. So I use the aspiration catheter to try to aspirate out the thrombus, but unfortunately the non-referral phenomenon occurred after the thrombectomy. So how to fix the non-referral phenomenon? First one, very important, is stay calm and to watch out the vital sign of the patient. Maybe the patient have the low hypertension, so I give the epinephrine 100 micro bolus. Then aspiration again. Then I give the patient adenosine 50, then 100 microgram from the aspiration catheter. Then use the small balloon, bigger balloon for the dilatation. Here's the result. This is the aspiration again. Then inject the adenosine. So the flow a little bit improved. Then use the small balloon for the distal, bigger balloon for the proximal. And then finally, I have to put the stent in the proximal of LAD. I got the TIMI-3 flow finally. There is another case for the elect PCI. This is the 50-years old male patient, have the diabetes, hypertension, and hyperlipidemia. He had the previous RCA infarction, but this time he's admitted for the LAD PCI. How do you think this kind of lesion? There is a diffuse lesion of the LAD from the proximal to the distal. And I carefully wire the Sion to the DB and the Sion blue to the LAD. But during that time, the DB's flow was affected. So I used the 2.5 balloon for the dilatation. As you can see, this kind of the lesion is very hard to open. Finally, I give the bigger pressure, so the lesion is open, but then I use the same balloon for the proximal, then the DB for the small balloon. This is after the balloon dilatation. The flow is quite good. But I use the bigger balloon, 3.0 balloon for the proximal LAD, then the smaller balloon for the DB1. After the dilatation, there is a taxation and the no reflow phenomenon occurred in the distal of the LAD. So how to fix this problem? First one is stay calm. Then the patient, watch out the patient, the vital sign. The patient have the drop blood pressure and the irritable. So, but unfortunately, my wire will be lost. So I should careful to wire it to LAD again. Then use the thrombectomy catheter to aspiration. Then use the catheter to inject the adenosine 50, 50, and 100 microgram. This is the flow after the adenosine. It's already improved. So I give the patient 4 metal jacket. Then this is the final result. It's acceptable. The TIMI-3 flow I get. Another case is for my rotor atherectomy PCI cases. This 78 years old male have the hypertension, diabetes, and the uremia. In the uremia case, we always encounter the very hard lesion, like a heavy calcification. So he have the electric PCI for the LAD, then staging PCI for the RCA. We prepare the rotor acceleratomy for the PCI. This is the original angio. There is a lot of calcification downstream of the RCA. So I use the 1.5 mini bird to have the rotor in the proximal RCA first. Then I encountered there's a very big calcification here. So after the fix this problem, I have another problem in the distal. So I have the several trials of the rotor acceleratomy. But after the several trials, I got the no-reflow phenomenon. So how to fix the no-reflow phenomenon for the rotor acceleratomy cases? First one, stay calm, and the patient, the blood pressure, the vital sign is stable. So I should very careful to keep the Y in the place, and force to flush the normal setting. I think this is important for the rotor acceleratomy cases, and maybe you can use the smaller balloon for the dilatation, have the improve the flow from the aorta. So for these cases, I also give the patient adenosine 50, 100, 100 microgram bolus. This is the small balloon, 1.5 balloon for the distal dilatations, and I give the adenosine. Then the blood flow is improved to the TIMI-3. Then I put the stent for the 4 metal jackets. So for the treatment of the no-reflow phenomenon, there is a flow chart. There is a separate to the different kind of situation. One is the primary PCI, one is elective cases. For the primary PCI, we have the aspiration, maybe the thrombectomy or direct stenting is useful. But another one is the elective PCI. For SVG PCI, I always use the filter wire, always. So it's prevent to the distal emboli. But if there is a no reflow phenomenon occurred, maybe there is a epicardial spasm. So we can use the nitro to dilate the vessel, or there is a dissection. We can use the IVUS to check out if there is a dissection. If there is a dissection, we just put the stent. And if there is a thrombus plaque shift, maybe we can stent in or use the anticoagulation more. Or if we have the no oblivious epicardial mechanism, maybe another reason for the no-reflow phenomenon is a microvascular reflow, the no-reflow. So I think adenosine is very useful because it's a fast on, fast off. So my favorite is the adenosine. So if there is still unworking, just try the vasodilator or the additional antiplatelet 2B3A inhibitor may be useful. So this is a pharmacological therapy. For me, adenosine is the first choice. And if the patient have the unstable vital sign, epinephrine also another choice. And thrombectomy. Thrombectomy if in the high thrombus burden patient is useful. How to prevent the non-reflow phenomenon? Because prevention is the best policy for the complication. So in the STEMI PCI, maybe you can consider to primary stenting or avoid high pressure post-dilatation. For the rotor accelerator, you may use the shorter bird runs, less than 20 seconds, or the low bird speed. And maybe another is the avoid to deceleration for more than 5,000 RPM. For the SVG PCI, always use the embolic protection device before you do everything. How about the outcome? Outcome of the no-reflow phenomenon is to decrease the 5-year survival after the STEMI, and it's a big difference for the no-reflow phenomenon cases. And if the no-reflow phenomenon occurred, the larger infarct size also reported. And the myocardium is damaged, so it will be increase the incidence of the systolic heart failure or the lethal arrhythmia. So it's my conclusion. No reflow phenomenon will be use the preventive measurement to predict the high-risk patient. If we have the high-risk patient or high-risk lesion, we should make the full prepare of in our mind. And maybe we can use the IVUS to check out what happened inside of the vessel. And to avoid aggressive standing, inflation or post-dilatation is also important. And maybe we can use the microcatheter for the distal deliver the vessel dilator, because for the vessel dilator always affect the blood pressure. During the no-reflow phenomenon, the patient is quite unstable. So keep the vital sign is more stable than everything. So distal deliver the drug maybe to have the less effect of the drug effect for the system effect. Then multiple use the vasodilator like my favorite adenosine, and another one maybe there's a lot of thrombus. You can use the 2B3A inhibitor or the epinephrine for the vessel. For the vital sign or the distal vessel dilatation, maybe helpful. Thank you.
Thank you. Dr. Yi is with us online. Go ahead, Dr. Amrit, you have a question, I think.
Thank you, Dr. Yi, for this great presentation. And that I think one of the most serious complications is no reflow. So especially if you have a hemodynamic instability, if you have any problem in your cath lab. So the point is, when do you decide to defer stent, to wait, not doing the action in the cath lab? So which patient you want to defer the stent, or do you want to continue on 2B3A before next angio?
Yeah, For this question, maybe I will check the IVUS first.
Yeah.
If there is a lot of thrombus burden, so maybe I will use the deferred stent strategy. Deferred stent strategy in the STEMI patient is useful. And you can use the 2B3A inhibitor and the dural antipyrotherapy, heparin. After several days, you recheck the angio. Maybe the flow will be restored already. So after the reduce the thrombus load, we can put the stent later.
Yeah, and I think one of the comment that when you're using the Rotor in elective cases, this is a very important point, tips and tricks during the Rotor. The most important thing is the short duration. This is very important when you're doing the Rotor, is to do short duration in Rotor ablation, and if you have a case, and also the infusion of saline during the Rotor. This is also very important, and don't go with high speed, because high speed always causes this complication. Thank you.
Dr. Awad.
Yeah, that's a very good presentation. You had it covered. But the thing that you kept repeating is to stay calm. I think that's the most difficult part of the management you're recommending, because, you know, when you said the patient was irritable, the operator was irritable, and everybody in the cath lab, when you get that, because it just wiped off all the good things you've just done to open the artery. The other thing you mentioned that I liked is to prevent no reflow. You have to expect it. You have to see it coming. Like usually the writing would be on the walls that no reflow is coming, and you have got only one bite at the cherry. The first inflation of your stent is the one that you have to get the most out of it. Usually post-dilatation, as you mentioned, is usually what gets you into trouble. And this I see all the time in the part of the world I work with. A lot of patients are late presenter. And the way we learn how to do it is just have one inflation, direct stenting. You have to size the vessel. We don't have IVUS, so we just size the vessel by eyeballing. That's a great presentation. Thank you very much. And the floor is open now for the question from the floor, if you would.
Any questions from the audience? Okay. I think great presentation. Thanks, Dr. Yi, for the cases and the presentation.
So today I'm going to speak regarding the practical method for no reflow treatment. Thank you, Mr. Chairman and the organizer, for the invitation. Actually, no reflow is the terminology used primarily, as you can see here in the left side, in the cath lab, where even after successful opening and stenting of the coronary artery, the coronary blood flow is not restored in the myocardium. So the point here to emphasize that the blood don't successfully going or reaching the site or reaching the muscles. So there is paradoxical situations that in spite the artery being open, but the myocardium is closed to receive blood flow. I'd like to call it as a myocardial epicardial dissociation. And here, how we feel after the usual midnight call for the primary PCR and thinking about the no reflow. Of course, it's negative, anxious feeling because serious complication actually could happen. So let's move now to my first case for today. I will present firstly 3 cases of no reflow management, and I will discuss here with you the practical methods to diagnose and manage no reflow in both effective and rapid way. This is a 43-year-old diabetic male patient, hypertensive, presented with anterior STEMI, failed thrombolysis, or after thrombolysis, patient had still ongoing chest pain, severe chest pain, so we had to take him to the cath lab. This is his right RCA. There is no significant lesions. This is the patient left coronary. As you can see here, the LED is occluded with big thrombus in the proximal segment with ectatic proximal LED. So actually here I was thinking what next. I was thinking actually in this stage to proceed with PCI. I was really thinking about no-reflow or thrombus propagation to the left main LCX with the expected catastrophic consequence. The other thought or other option is to stop here and start IV 2B3A inhibitors with a plan of relock later. But I choose to go with PCI as the patient had acute situation and ongoing chest pain. I crossed successfully the occlusion with the workhorse wire. Thrombectomy was used. I succeeded only to get out of small debris out of the LED. But actually there is no much improvement at this step. So here, actually, I need to confirm, or my priority here to exclude any other possibility of limiting the contrast propagation distally to the vessels. As you know, there is many other causes that can cause limiting propagation of the contrast or acute occlusion of the vessels, like spasm, hematoma, dissections, or even big thrombus, as in our patients here. So these factors actually could have similar angiography and the clinical presentation as no-reflow. So here I went distally with the microcatheter distal to the occlusion. I need to visualize the vessel distal to the that big thrombus to evaluate or to rule out if the really cause of the limiting blood flow here is the thrombus rather than rather than no-reflow itself. So here, as you can see here, I confirmed that there is a really good filling distally to the occlusion. So I realized here that the main cause of the limiting blood or contrast propagation distal to the occlusion is the big thrombus. I invested more to the aspiration with also distal administration of drugs, adenosine, nitroprusides, and 2B3A inhibitor distal to the occlusion. After that, I had this is the final angiography after my many trials of getting out the thrombus. I think, and I was really happy with this result at the end of this procedure. I kept the patient in the CCU. I gave him IP2P3 inhibitors. I had a relock after 48 hours, and this is the angio after 48 hours. Timmy, we can call it like 2 to 3 flow, and I discharged a patient from the hospital safely. Of course, on dual antiplatelets, EF 49%, and the patient without significant symptoms. Now I'm moving to the next case, and let's discuss it in comparison to my previous case. This is another male patient, 49 years old, history of PCI to distal RCA. He presented with inferior STEMI, failed thrombolysis, so he transferred for rescue PCI. This is his left system, no significant diseases in LAD or LCX, but this is his RCA occluded distally at the side of the stent. Here I succeeded also to passing the wire distally, and as my fixed method to treat Reflow, I also go distally with the microcatheter. But here, if you can compare this injection distal to the occlusion to the previous one, you can see here the distal coronary opacification is not that good, or there is occlusion, the opacification is not that much after injecting inside the micro catheter. So here I confirmed the main problem here is the no-reflow, the microvascular disease. So I kept my MC distally. I gave as much as I can of drugs, adenosine, nitroprusides, 2B3A inhibitor intracoronary into distal bed of the coronary, because as in the first presentation, if it's better not to give your drug in the guiding, because by definition it wouldn't reach distally, and only you can have the systemic effect of the drug. So it's better to give drug in the microcatheter distally. At this stage, the vessel is partially opened. I had now a better flow distal to the lesion, and the distal flow was better. So I decided to stent. I used direct stenting imaging. And why I use imaging here? Because I need to evaluate stent apposition and expansion to limit NC post-dilatation, which could lead to increase the no-reflow itself. And this is my final result and final angio after stenting. For me, it was accepted result to flow after this all decreased flow, no reflow. So I accepted this result at that time. I sent the patient to, or I shifted the patient to CCU. I continue IV to B3A inhibitor for 24 hours. A patient also, fortunately, he discharged on DAPT. I followed him in the OPD, and he is symptomatic. My final case for today, I want to emphasize here the importance of SVG, or venous graft, as a common vessel-causing non-reflow. This is also a patient, 51 years old, male, diabetic, ischemic, non-ischemic heart disease. He had a CABG 1 year ago, 2 venous pair grafts, one to LED and the other to OM. Lima not used at the patient was emergency, and there is no any time for mammary harvesting. Patient presented with non-STEMI, with on and off severe chest pain, so we took the patient to the cath lab. This is patient coronary angiography. As you can see here, his left system occluded LED, extensive disease in the ramus and in the OM. In the RCA, there is a mid-significant lesion also. This is his SVG to the OM. It's patent with good distal flow to the OM branch. Now, please have a look to this SVG to the LED. Here we have occlusion. As you can see here, the vessel is occluded distally. There is haziness here, or what we can call tight lesion, and there is really pretty small filling retro to the two big diagonal branches, as you can see here. So I want to think about the plan. Of course, I didn't do any ad hoc PCI. I stopped my procedure, and I thought about open the native LED, then I go stage PCI to the mid RCA. My plan was to open this LED retrogradely because antegrade, I don't have too many good stump to go antegradely. So I used the SVG as a conduit or as a track to go retrogradely, but unfortunately, after I wired the graft, I also had the no reflow and I lost totally the visualization, and the patient developed severe chest pain with ST elevation in his anterior leads. But fortunately, at this stage, I have MC inside the vessel. I gave immediately adenosine nitroprusside 2B3A inside the microcatheter. Fortunately, that helped me to open the distal visualization, and I can see now a patient clinically became better and the flow was restored. So I completed the procedure. As a standard, I went retrogradely. I opened the vessel from the antegrade, from the retrograde, and now I have the flow. I stented the vessel. I was guided, so I limited as I can the NC dilatation or post dilatation. But after I finished opening the LED, I chose to occlude or to coil that SVG. I used to coil that to occlude that SVG. I don't want more microembolization distally to affect the vessel. The LED that I opened, especially the distal bed, is Fuseli disease. So I called the SVG. And this is the final angio after before shifting the patient to CCU with a plan to PCI to RCA later and relook for the LED 2 months later. I did relook, but unfortunately I don't have the angio today. The SVG is completely occluded and LED distally is growth, and I optimize the LED stents. So in conclusion, the no reflow phenomena actually is a common and your plan to manage neuroflow should include differentiation between different causes of acute vessel closure. And if no reflow happened, please go with MC distally to use it to give your drugs. Multiple pre-dilatation, stents over inflation, and aggressive post-dilatation should be avoided. Thank you very much for your attention.
Thank you.
Thank you. Thank you, Dr. Ahmed, for this great cases, wallah. Glad you successfully managed them. I have the panel here.
Yeah, thank you, Ahmed. Amrit Hadidi, very great cases, and I'm very happy with this, with your result. The point is the last case. What about the cabbage patient? So from the start, this patient was referred to you after cabbage, not because the patient. I think this patient was young patient. I think if before cabbage you can do CTO for the LED, I think this is one of the good option for this patient. But the point is, you are using this vein graft as a conduit for the retrograde. Yes, it's good. But the point, as you mentioned, in acute setting, that we have no reflow, definitely because of this thrombus burden. And from my point of view, I will try antegrade in this case first. If not, so we use the vein graft as a conduit, and it's very good result because if this, as what happened, that you have no reflow, so the patient was hemodynamically unstable, severe chest pain, and I think and very good point from you that you occlude this vein graft, because there will be a very bad result on your stents if you don't include this vein graft. Thank you, Ahmed, for this.
Thank you.
Thank you, Dr. Amr, for your comments.
Let me shed a light here regarding in such cases For how long do you think we should continue the DAPT? We extended beyond 1 year?
Yeah.
Yes, actually, my strategy to using DAPT is according to patient risk of bleeding and risk of thrombosis. If, of course, his risk of bleeding is low, I will be very happy to give him DAPT for 3 or even more years. Even I could combine it aspirin like with NOACs, for example, in such cases if the bleeding risk is low. But if of course the bleeding risk is high, you can tailor every by case to case according to the risk of bleeding versus thrombosis.
I see.
Great,
Abdallah.
great cases. This is so different cases, different outcome. But I mean, sometimes you didn't get this outcome, which is very nice here. I think we still don't understand this phenomena. I think we need to learn more because you have a perfusion, reperfusion of epicardial, and you have problem with perfusion of the microvascular. So something we are doing it, or something is happening, and we are accelerating it. So that phenomena, how to manage, I think everyone said here, preventive measure, which you've taken, using something to make the diagnosis like IVUS, then use vasodilator. But these are still, we've been doing this for a long time. Nothing new coming. Anything else you want to, maybe anyone to suggest? I've not heard anything new.
The point is the no-reflow started before entering the cath lab. This is the point. The point of presentation of the patient, the time of duration of infarction, definitely if the patient is uncontrolled, the patient blood pressure is not controlled, and I think to reduce the no-reflow, you need to prepare the patient as fast as you can, and the door to balloon is very short. And if you have a delay, so expect to have a no-reflow. So be ready in the cath lab. This is a very important point.
Okay. Thank you all. Okay, let's move on to the next speaker, Dr. Amrit Hadidi, case presentation. And I would love, thank you, Dr. Ahmed from Kuwait.
Thank you, and thank you for the invitation.
Okay, go ahead, Dr. Amrit.
First of all, I'd like to thank Dr. Abdallah and Dr. Musa for inviting me to this elegant meeting. Definitely the complication we face make us more stable in the cath lab. And I think this is the idea of your meeting. And I hope that will be bigger and bigger, inshallah, next year. My talk today is a case of no-reflow. So, as Dr. Abdallah said, this is very important. The main goal is to have a good flow in these arteries. But sometimes when you are getting the flow inside the artery, still you have no improvement in the tissue perfusion. And this is becomes a phenomenon. This is a no-reflow. So this is the point, the difference between that you have a vessel but no distal perfusion. And the point is when you have inadequate myocardial perfusion through this given segment of coronary circulation without angiographic evidence of any mechanical tissue obstruction, this is a no-reflow phenomenon. And this is always happen after, especially in most cases of primary PCI, definitely as a mechanical complication. So you categorize your patients as have sustained no-reflow. This is a result of anatomical irreversible changes. This is a very bad result. And the other one is the most important thing is the reversible no-reflow. And this is one of the functional and reversible change in the microcirculation. And this is the pathophysiology. We need to concentrate in this pathogenic component of no-reflow, distal embolization ischemic injury, reperfusion injury, and individual susceptibility. And you have a very different patient susceptible for this coronary microcirculation. And this is the behind the phenomena why no reflow is still, we have a lot of things to study about this phenomena. And the most important tool to diagnose is during angiography is the final TIMI flow is less than 2, and the myocardial blush grade is less than 2 from 0 to 1. And also you need to count the time frame count, because if slow, so it's have a diagnosis of no reflow. So this is an example of our case. This patient, female patient with anterior STEMI and have all the risk factors. And this patient presenting with, as we see here, occlusion of LED, total occlusion, and then we find that we have no distal flow. So, and this is the right coronary, as you see, with good flow and no any significant lesion. So the decision is to use small balloon, according to the guidelines, with small balloon, and then we have some flow inside the artery, as you see, and don't to try to go too much manipulation, ballooning, and so we go direct stent, and this is sometimes a very bad point when you have a still slow flow in your artery, and this is after stenting. You will see that there is no flow inside your artery after stenting. This is a very bad thing. So what to do? This is one of the points is use aspiration catheter. This is important. Number two, you can, if you still have no flow in your artery, so you can inject through this aspiration catheter. Sometimes you can use adenosine in this case, and it was very successful. As you see, there is improvement, and with a lot of aspiration again, and then we have a good flow, still definitely slow, but still we have flow, and this patient, and this is the final result of our patient, still good flow, but still a grade 2, TIMI grade 2. This is another case of inferior STEMI patient, and this patient has occlusion, as you see in the RCA. LED is good, but the point is the LED gives some collaterals to the distal RCA. We will see there is a benefit of this. If you're working a CTO, so you will know now the benefit of this retrograde filling. When you are using the wire now, you are putting the wire in the RCA, and try to use the thrombus aspiration, because I saw that this patient has a lot of thrombus burden. So we use several balloon inflation after aspiration, but is not responding. So now we have no reflow in the RCA. So what to do? This after aspiration, after repeated balloon inflation, you still have, if you inject from the contralateral, you see the wire in the RV branch. So you need to, if you have a good option to have a contralateral injection, this is a very important point, that you have now the distal RCA can be seen from the retrograde. And then you adjust your wire distally in the RCA, and you try another several balloon inflation, but still the flow is not good, so use 2B3A inhibitor injected through this, the guiding catheter. And then the point is sometimes you use the contralateral injection to adjust your stent. When you are putting the stent and try to get the position, we cannot see because of this thrombus and the heavy thrombus burden and the lesion, and you can now adjust your stent before the bifurcation, and now you have, after putting the stent, still you have distal embolization, and we use a bigger stent to try to get some flow, because we know that the flow distally is okay from the retrograde. Now we have good flow, but still you have a very large thrombus burden after putting the stents. This is a very bad point. And that, after several balloon inflation, and it's to try to fragment these thrombi, and then after putting the stent, so this is the final result with good flow in this huge, big RCA. This is another example of a patient with inferior STEMI, and this patient, as you see, is bradycardic and have as you see, the RCA is mid-segment occlusion with thrombus. We try to use a small balloon, we have some flow, and now we try to cover it fast because we don't want to balloon more, because after stenting you can still have no reflow. So what is the point to do? Is try to do aspiration. Yes, we do. We do temporary pacemaker. This is very important point in your tool because this patient will be hemodynamically unstable. So you fast put in case of right, especially you can have an access for any emergency. Number two is to try to go with the aspiration catheter, but still there is no good flow. And this is one of the important points. You can inject through aspiration catheter, as you see here, the contrast to see where is any mechanical obstruction or any dissection. Sometimes IVUS can help, but in this scenario, we give the epinephrine 100 microgram, and this patient continued on 2B3A, and this is the final. Still, there is slow flow, but still this patient will continue on 2B3A for 2 days and then come back, and now with a better result. We need to put in mind, this is your algorithm for the treatment of no-reflow. First, you need to assess where is the no-reflow, what's the cause. And this is a spasm or thrombus or dissection or air embolism. You need to look for another cause. So the help is sometimes the IVUS can help you. You need to check the ACT. This is a forgotten thing that you need to check the ACT. ACT is important, especially if you have a large thrombus burden. Sometimes hemodynamic stabilization, either using sometimes in some cases, you can use intra-aortic balloon, you can use a temporary pacemaker if you have a problem in the patient bradycardic, and you infuse through the microcatheter or the aspiration catheter adenosine up to 60 microgram bolus, and the verapamil and nitroprusside some cases, and epinephrine is an important tool in some cases and is the only helpful one. And if you divided according the pathophysiology based management of your no-reflow, if this patient's distal embolization, so the pharmacologic strategy as 2B3A, vasodilator, adenosine, nitroprusside, and if this patient has ischemia or reperfusion injury, also beside this pharmacological strategy, you need to have an intra-aortic balloon, or sometimes you can help with a pacemaker. Also, the management of this patient, as we mentioned, those patients who are highly susceptible for no-reflow are those patients who are uncontrolled. The blood pressure is not controlled, the blood sugar is not controlled, and those patients are highly dyslipidemic. And so these patients, if you control, you can have a reduction of no-reflow. So to prevent, as we mentioned, short door to balloon time, you need optimal blood pressure, and definitely sometimes use intracoronary dilator and thrombus aspiration if present. Also, you need to diagnose, as we mentioned before, and very important to have, if you have patient with no-reflow and this patient has a more infarct expansion and ventricular arrhythmia, and why this is a on the back on the high cardiovascular mortality. So these patients are very high risk patients, and you can use adenosine, nitroprusside, and nicardipine, verapamil in your case. Thank you.
Thank you, Dr. Amr, for this great presentation. Great.
So we're waiting for you in Cairo CTO.
Inshallah.
Inshallah.
Dr. Awad.
Thank you, Amr. That was a very nice presentation. Do you think imaging has any role in helping out how we choose how to manage this complication, or no role for imaging at all?
Imaging is important in this case, especially if you need to decide what is the cause of this problem. Sometimes you have an edge dissection, and if you cover it with a stent, so the problem solve it. So this is the point. Imaging is very important, and also how do you be stable in the cath lab, and also to check if you don't have an IVUS, you can go distally and inject small injection with the contrast to see if there are any dissection or any mechanical complications that are obstructing your flow.
I see. We have one question from the audience.
Short comments on the question. I think we should differentiate between no-reflow phenomena before deployment of the stent and after deployment of the stent. After deployment of the stent, it is sure microvascular distal obstruction, and we need to manage directly. But before deployment of the stent, we should differentiate between maybe reclusion again of the lesion, maybe dissection of the lesion. So we should use microcatheter and inject distally if there is a flow, so we can deploy direct stent for the lesion. This is my comments. My question about your experience about norepinephrine injection distally. What about the complication? I know that norepinephrine can induce VTAC, VF. So what's your experience about norepinephrine distally?
For me, epinephrine is one of the important tools in your hand because it's sometimes you have no other alternative. The point is you need to dilate the norepinephrine. You need to dilate it 3 times. If you have 1 centimeter from the epinephrine, you need to dilate to avoid what you mentioned, that you have a VTAC or VF. This is a very serious complication after. But sometimes it helps. If you're using the usual routine, this is not the first action, but it's very helpful in some failed cases to regain the flow again.
So we cannot say no reflow phenomena until we put a stent. That's what you're trying to say, Doctor? Yani, because in that way, if you do ballooning for a long time, and then to see if that's if you think okay, still no dissection there, that you can you call that no reflow, or you have to put a stent then say no reflow? Because that's really is another.
To Colombo about the testing of the appropriate, this is called appropriate vessel occlusion after balloon inflation. So we don't know the mechanism. Maybe appropriate re-occlusion again by thrombus, high thrombus burden, maybe dissection by balloon induced, and maybe neuroflow phenomena. So this is technique by Antonio Colombo. We make distal injection of contrast beyond the lesion itself. If there is a flow, so we can deploy stent directly. If there is no flow distal beyond the lesion, it is microvascular obstruction, and we should manage.
I see. All right. Thanks.
Just last comment.
Yes, please.
Don't go out of the cath lab with no flow. This is an important point. You need to have some flow, even one at grade 1, because if you have still no flow, it will still occlude it.
You don't go worse than what you come in, and you don't want to lose more arteries. Just one artery is enough.
Yeah.
Thank you.
Thanks, Dr. Amr, and thank